10 बजे के बाद 5-7 मिनट आगे पीछे होने से चलेगा। ये सभी प्रेजेंटेशन मेरे पास होती है ना, मैं शुरू भी कर देती हूँ। मेरे पास प्रेजेंटेशन है, सच्ची प्रेजेंटेशन नहीं है, चलो मैं सवाल नहीं है। तो ठीक है, जाएगा इन पर नहीं है परीक्षा में नंबर है क्या? ऐसा परीक्षा हमारे जो बनाए जैसे ना सब बता सकते हैं फरवरी के लिए क्लास कर रहे हैं तो और वॉच डालना बता दीजिए मुझे कौन वॉच लगाऊंगा मालूम नहीं आ रहा है कि मेरा इसको कौन कर सकते हैं काम वॉच में सारा ट्राई करता नहीं है हमारे में कौन श्रेया भी वॉच होगी और कौन आकांक्षा गुप्ता भी होती है हमारे में देखो तो कौन आकांक्षा गुप्ता जो हमारी जी आ रहा है मुझे तो क्या पता है फोटो होते हैं मुझे पता ही फोटो कौन है
हेलो LT2 कब? अरे मेरे पास कहाँ से क्लास है मेरे पास?
हेलो
हैं? अभी 10 बजे। हाँ अरे तो मैं पहले क्लास तो करा लूँ।
क्या करेंगे
LT3 वाले को फोन करने के लिए ठीक है मैं अभी क्लास करा के जा रहा हूँ। ये तो मतलब भैया कम से कम उसको तो बोल सकते हो आप लोग LT3 वाले को। चलो ठीक है मैं कर दूँगा ठीक है। नहीं वो फोन वाला ही करेंगे कैसे करना है।
कल बात हुई थी ना शायद मोनिका मैम से।
नहीं बात तो हुआ था
तो मतलब वो पाएगा प्रोजेक्शन तो करवा दो।
नहीं तो पाएगा फिर नहीं पाएगा
करा दीजिए तो
मैं देखना पड़ता है।
सर को भी देर लगेंगे 5-10 मिनट ना तो ठीक है ना 5-10 मिनट आगे पीछे
मेरे को तो 1 मिनट लगेगा
नहीं हमें कुछ नहीं वैसे
कोई
स्टूडेंट्स के लिए तो कोई प्रॉब्लम नहीं है ना इसमें स्टूडेंट्स को यहाँ पे
करना शुरू ऑनलाइन वो हो गया कनेक्ट शुरू में 10 मिनट
सर वो प्रेजेंटेशन आप ही बोल रहे हैं
देख लो आप
जी लगा दीजिए
फर्स्ट वाला हाँ एक और दिखा दो सारी स्लाइड
आपको ना पिछली बार ये बोल रहे थे ना कि जो कैमरा लगाते हो उसमें ना हमारा फेस आना चाहिए, जैसे सर का फेस आना चाहिए, वो आप चेक कर लो। किसी का ना ऐसे हुआ था कि फेस नहीं आ रहा था, तो वो लोग आप चेक कर लेते दिखाइए। हाँ सर का फेस अभी आ रहा है, ठीक है सर।
स्टूडेंट से पूछो रेडी है क्या गुड मॉर्निंग सुन भी रहे आई होप ऑल ऑफ यू हैड ब्रेकफास्ट इन द मॉर्निंग एंड topic for today's lecture is malignant lesions of uterus. Last time you had a class on benign lesions of uterus and today it is on malignant lesion of uterus. So today now we will be speaking about malignancies arising from body of uterus. For malignancies arising from cervix, there is a separate lecture. Malignancies in uterus mostly arise from endometrial lining and they are called as endometrial carcinomas. But at times malignancies can start from the structures within the myometrium and they are called as sarcomas. Endometrial carcinoma is far more common. Of all malignant lesion of uterus, endometrial carcinoma comprise about 95%. Sarcomas are hardly 5%. And as you will be listening, there is a lot of difference between the outcome prognosis in two types. I am sure you all know that in India, commonest cancer arising from female genital tract is cancer cervix. Number 2 is ovarian carcinoma and endometrial carcinoma is number 3. But situation is not same in other countries. If we were to go to America, UK, Europe and most rich countries, from female genital tract commonest malignancy is endometrial carcinoma. Why such a difference? I'll request all of you to just think over. Around about 30-40 years back, the situation about malignancies was same in America, Europe, Canada, other places. Their cancer cervix used to be the commonest and endometrial carcinoma was lower down. But things have changed drastically in last 30 to 40 years. they hardly see CA cervix, and one main reason for this is that in between 1940 and 1960 we discovered that carcinoma cervix is one disease which exists almost for 10 years in pre-invasive stage, and around same time we had pap smear availability, and we realized that if we were to do pap smear for all women, it is possible to pick up CA cervix before actually disease develops. So those countries which introduce a pap smear screening program for women were able to drastically reduce incidence of CA cervix. Somehow in our country we have not been able to do such a thing. We have pap smear facility, but they are available only in big hospitals, and it is offered to those patients who come to hospital. Now endometrial cancer is also becoming more common in developed countries for one more reason, and that is increasing body weight or obesity. As you will see subsequently, a patient who after menopause has excess of estrogen in her body is more likely to develop endometrial carcinoma. Normally after menopause, when ovaries stop functioning, there is hardly very little amount of estrogen, and these women do not have any significant risk of developing endometrial carcinoma. But in those patients who are obese, who are taking estrogen hormone for hormone replacement after menopause, women who are being given tamoxifen, as a treatment of follow-up of breast cancer. So these women where there is a excess source of estrogen either coming from outside body or from within the body after menopause have a high risk of developing endometrial cancer. In addition, we also know if patient has polycystic ovary, she is more likely to have an ovulation and also excess of estrogen in body. There are some families where there is an increased risk of developing endometrial cancer. There is one syndrome called a Lynch syndrome, and this is related to mismatched genes. If anyone has Lynch syndrome, he is more likely to have endometrial cancer and also carcinoma colon. So we know quite a lot that who is likely to develop endometrial cancer, and main precise reason seems to be excess of estrogen after menopause in the body, and this estrogen may be exogenous in source or endogenous in source. When we sit in OPD, we see most patients who have endometrial cancer tend to be obese and hypertensive. Whether hypertension and diabetes directly predisposed to these women to develop endometrial cancer or it just coexists, that is not very clear, because after all diabetes and hypertension are two common diseases which is seen in the general population. But in actual practice, when we see a case of endometrial cancer, more chances are that she will be overweight, she will be hypertensive and diabetic. Most patients who develop endometrial cancer have either history of infertility or they have 1 or 2 children. This is in contrast to cancer cervix. In cancer cervix, mostly patients are those who are multiparous, who got married early, had started sexual activity early, have repeated childbirth. But on the other hand, endometrial cancer patients are more likely to be those who have either no child or have just 1 or 2 children. As I mentioned earlier, that in India also we are seeing a change in the trend. Earlier we used to see mainly cancer cervix, but now we are seeing more and more of endometrial cancer, and one reason could be that lifespan of women in India has increased. Currently, lifespan of women in India is around 68 years, whereas 20 years back it was 48. So longer one lives, more likely she may have disease. Another reason is in India also we are becoming richer. When you walk in the market, you see a lot of people who are overweight, and this is all because of economic prosperity. So as lifestyle changes, as we become richer, as we become overweight, in India also we will have more and more of this disease. You will be surprised to know, when I became a MD student at AIIMS, in first year I saw only one case of endometrial cancer against almost 180 cases of CA cervix. And over a year what has happened? We started seeing one case per month, then one case per week, and current situation is when we sit in gynae OPD, we see almost 2 or 3 new cases of cancer endometrium in every OPD. So in India also endometrial cancer is becoming commoner. In future, when we have very effective screening program for cancer cervix, probably we will be in the same situation as we have in America and UK, and where we are able to diagnose cancer cervix much before it actually turns cancerous. It is easy to diagnose cancer cervix, cancer endometrium. Most patients, almost 75% or more, are post-menopausal, and the reason is the first symptom which may appear is post-menopausal bleeding. And fortunately, it is such a common knowledge among women, even in villages, that if somebody has bleeding after she had attained menopause, she knows there is some serious disease inside. So now she then tends to consult doctor, so she is diagnosed early. Whereas in CA cervix, in early stages, there are no such symptoms. She just may have increased discharge and she tends to ignore it. So it is a very good thing that in cancer endometrium, because symptoms are such that women consults a health personnel early, that most cases we tend to diagnose when disease is limited only to body of uterus and it has not spread to the surrounding structure. So that is one big difference about CA endometrium, and it also makes difference in their treatment and in their survival. Sometimes women may present with excessive mucoid discharge after she had menopause. Normally after menopause, because estrogens are not there, the discharge decreases, vagina becomes dry, atrophic. But on the other hand, if she has excessive discharge, especially mucoid discharge, we need to examine her. It can be either coming from cervix, or this discharge could be coming from endometrium. In last 10 or 15 years, we are seeing another change. Earlier, most patients with endometrial cancer were post-menopausal. Average age at which this disease develops was 59 to 60 years. But now we are seeing patients as young as 35 years, 40 years who have endometrial cancer. And in them, the presentation is different. And they were having menses, but they now notice bleeding in between periods, intermenstrual bleeding or continuous bleeding. And these women who are pre-menopausal have irregular menstrual bleeding. When we do their endometrial biopsy by doing either a DNC or endometrial aspirate, histology tells us no, actually she has endometrial carcinoma. Of late, we have seen as young girls as 30-year-old with endometrial cancer. And what we found, they had been married but they were not able to have children. She is obese. She was diagnosed with polycystic ovaries. So there is excess of estrogen in her body. And when there is excess of estrogen, how exactly it predisposes a person to endometrial cancer? Whenever there is excess of estrogen, it leads to over proliferation of endometrial lining. So endometrium undergoes endometrial hyperplasia, and if this hyperplasia is of extreme degree, where even nuclear changes take place, then it is a pre-malignant state. So in any person where endometrial biopsy shows endometrial hyperplasia with nuclear atypia, it is a pre-cancerous stage. And if we don't take adequate steps, it ultimately will become malignant. In fact, in some of the patients when endometrial biopsy shows endometrial hyperplasia with atypia, there already may be a small focus of carcinoma. So sitting in our OPD, when we have women either coming with post-menopausal bleeding, or she is not yet menopausal but she has heavy menstrual bleeding, irregular menstrual bleeding, and on endometrial biopsy if we find she has endometrial hyperplasia with atypia, we get concerned. We know that there is a small chance that already carcinoma of endometrium has begun in this patient, and we treat them aggressively. So post-menopausal bleeding, excessive discharge in the post-menopausal stage, and irregular period, especially after the age of 40 years, should raise a suspicion that she actually may have a endometrial carcinoma. Very rarely we find that she has a endometrial carcinoma when she had come to us with pain abdomen. Normally after menopause we hardly have pain in the abdomen, and if at all pain is there in lower abdomen, it is likely to be due to some other pathology Maybe she has urinary infection, she has colitis. But some of the patient who have endometrial cancer may have a pain, crampy pain in the lower abdomen, and it is so peculiar about this pain. This lady will have pain every day at the same time, and it lasts for almost same duration, in some half an hour, in some 45 minutes, and it disappears. So this is a rare manifestation or presentation of endometrial carcinoma. So once we have a patient where we suspect she has endometrial carcinoma, next things comes, how do we confirm our diagnosis? So in OPD, what we do, after we do her per speculum examination, PV, we like to do a transvaginal ultrasound for her. That is the first thing. Normally when we are doing per speculum and PV, we do take pap smear, but pap smear is mainly for cervical region. A negative pap smear in this kind of presentation will not rule out endometrial cancer. She may have endometrial cancer, yet pap smear will be normal. So to confirm our diagnosis, we first do transvaginal ultrasound, and in transvaginal ultrasound we measure endometrial thickness. Normally after menopause, endometrium lining becomes thin. It is 3 mm or at the most 4 mm in thickness. But if we have a postmenopausal patient where thickness is more than 4 mm, then there is a chance that she may actually be having some pathology in the endometrium. After doing transvaginal ultrasound for these women, next thing we want to obtain a tissue from endometrium. So we want to take a biopsy from endometrium, and there are several ways of obtaining biopsy. Simplest thing is we do what is called as EA, endometrial aspirate. During your 4th and 5th year semester posting, when you came to gynae OPD, you had seen that this is one of the commonest minor procedure we do in our minor OT, EA. So after she has passed urine, we place her in lithotomy position, clean and drape the part, and then we introduce sim speculum and catch anterior lip of cervix with valsellum or tenaculum. And first thing, we introduce a uterine sound to know exact length of the uterine cavity, and after that we introduce a Karman cannula, that flexible cannula which is 4 mm in diameter, and we attach this cannula to a 20 mm syringe, and we suck out the endometrial tissue. And this tissue which we obtain from endometrium, we will send it to pathology department after putting in formalin bottle. But at the same time, in the same sitting, we also obtained a little tissue from endocervical canal, that we call as ECC, endocervical curettage. So that will help us to know whether there is any other region which exists in endocervical canal and causing same symptom. So in actual practice, we always do EA plus ECC in this patient, and we may first like to do ECC, then do endometrial aspirate. In some of the hospital, instead of doing EACC, they do what is called a fractional curettage. Some people do DNC. They will dilate internal os, and after dilating internal os, then they introduce a metal curate, blunt and sharp curate, and curate the endometrial lining. In DNC, we take tissue only from endometrial lining. In fractional curettage, we take two specimens. One we take from endometrial lining body of uterus, and second is from endocervical canal. But it is same thing. To confirm our suspicion of endometrial carcinoma, we need endometrial tissue, and that only will tell us whether she has an endometrial carcinoma or she has some other disease which is causing her this symptom. Nowadays, as things improve, what people do, a patient who has come with postmenopausal bleeding, when she is posted for endometrial aspiration and curettage, they first visualize inner lining of endometrium by hysteroscopy, and after they have seen whole of endometrial lining, then they do either curettage or EA. So that is hysteroscopy. Advantage of hysteroscopy is that if there is a small focus of carcinoma, we will not miss it. But if we are doing only blind endometrial aspirate, sometime we may miss it. So these are various ways how we obtain a endometrial biopsy tissue and subject it to histopathology. And when we get a report, most of the time they tell us that she has a endometrioid variety of adenocarcinoma. In about 80% on histology, pathologists tell that yes, she has an endometrial carcinoma and it is endometrioid variety. And when they send us report, they also tell us whether it is well differentiated, moderately differentiated or poorly differentiated. G1, G2, G3. Grading is done this way. But in about 20%, they tell us there is a carcinoma, but it is a different variety. It can be a clear cell carcinoma. It can be a papillary serous type of carcinoma. So does it matter whether she has a endometrioid adenocarcinoma or whether she has a less common type, a clear cell variety or papillary serous type? Yes, it does matter. So majority of the women will have a endometrioid carcinoma. They have a better prognosis. This type of carcinoma is called as type 1 endometrial carcinoma. On the other hand, if histology is other than endometrioid variety, it is grouped under type 2. People have also seen endometrioid carcinoma or type 1 is mostly seen in those patients who were overweight, obese, and it seems to be related to excess of estrogen. Whereas in type 2 variety, we may have carcinoma where patient is thin built, there is nothing suggestive of excess of estrogen. Age wise also, type 2 variety is more often seen in elderly patient. Patient may be 69, 70, more than 70. There is another difference between two types of endometrial cancers. When we operate this patient, in type 1 mostly we find she has a disease limited to body of uterus, whereas in type 2 we may find patient when we open the abdomen, she already has a widespread disease. Disease may have spread outside uterus to involve momentum, other structures. And even after treatment, after surgery, when we treat this patient, in type 1 they have a good survival chances. They will become disease free and will remain disease free for a long time. On the other hand, in type 2 variety, in spite of best treatment, surgery followed by radiotherapy, chemotherapy, they have recurrence, and most of them die within next 1.5 years. So based upon histology and also clinical feature, we see two varieties of endometrial carcinomas. This is what I just described. 80% are endometrioid variety, but there are less common type. Like any other cancer, we have staging for endometrial cancer also. And like any other cancer, there are 4 stages. The last staging were described by this International Federation of Gynae and Obstetric Societies, FIGO, which we follow. If you find disease limited to body of uterus, it is stage 1, and stage 1 is further divided into 1A and 1B. If disease involves only endometrium, or if it is invading myometrium but less than half thickness, it is stage 1A. But if invasion is more than half thickness of uterus, then it becomes stage 1B. So greater it goes into the depth of myometrium, higher the chance that disease will spread to surrounding structure, to lymph nodes. And as I had mentioned earlier, when we get a biopsy report showing endometrial carcinoma, they usually tell us whether it is well differentiated G1 or whether it is moderately differentiated G2 or poorly differentiated. So if a patient has a disease which is limited to body of uterus, the differentiation also tells us prognosis and chance that disease may have spread to her lymph nodes. Little later disease may spread, it may spread downward to involve endocervix. And if there is involvement of endocervix, where actually stroma is involved on histology, we call it as a stage 2 disease. And still not treated, disease can spread in other direction. It can go downwards to involve vagina, it can go laterally to involve parametrium, it can invade whole thickness of uterus, and it then can spread to lymph nodes. So stage 3 is a disease which has spread, and stage 3 we divide into 3A, 3B and 3C, depending that in which direction the disease has spread. When it invades whole thickness of uterus and involves tubes and ovaries, it is 3A. When it spread downwards and involves vagina and parameter, 3B. And when it spreads to lymph nodes, pelvis and periaortic region, then this tumor becomes stage 3C. And if still not treated, in next stage the disease can involve bladder anteriorly, rectum, and even may spread to structures like lungs, liver and other structures. So like any other cancer, there are 4 stages. After we have diagnosed, we have assessed what stage she could be, we like to operate almost all patients. Only exception will be that she already has a lung metastasis, liver metastasis. Otherwise, we like to operate almost all patients. So that means stage 1 patient, stage 2, even 3 we like to operate. The first step is operation, and in this operation we aim to remove uterus with cervix, both tubes and both ovaries, and also lymph nodes. So as I mentioned, if we by chance know that she already has a lung metastasis or liver metastasis, then we avoid operation. We know she is stage 4. Otherwise, first step in the management is surgery, and when after surgery we also come to know whether she requires post-operative radiotherapy. So the treatment of C. endometrium is surgery followed by post-operative radiotherapy. Only in some patients who develop recurrences where disease is already widespread, that we may like to treat by giving chemotherapy. Otherwise, main mode of treating C. endometrium is surgery followed by post-operative radiotherapy. This was one case where we operated. So we had removed her body of uterus with cervix, tubes and ovaries, and in the body of uterus we saw this growth which is measuring roughly 4 centimeter. This was another patient where cervix was looking normal, but we saw a big growth in the endometrium, and it was invading more than half thickness of myometrium. And when we operate, there is a fixed operative procedure which we follow. Although we can do surgery either by laparoscopy approach or by open approach, but we follow same step. As soon as we reach peritoneal cavity, first thing we do is look for any ascites. If it is not there, we pour about 200 ml of saline in the peritoneal cavity and we suck it out. So that is peritoneal washings for cytology. After this first step, then we carefully feel for uterus, cervix, ovaries, tube, and also try to see if there is a disease which may have spread elsewhere. It may have spread to omentum, liver, other thing. And after doing thorough inspection and palpation, then we proceed with the surgery. And when we operate this patient, we always remove uterus with cervix, both ovaries and tubes. So this is what is minimum part of surgery. And as soon as we take out the uterus from operative field, we request one of our assistant, we tell, please cut open the specimen, show us inner side of the specimen. And when we find tumor is measuring more than 4 centimeter, tumor is invading more than half thickness of myometrium, tumor is going in a downward direction to involve endocervix, then we know that in this patient we should remove lymph node also. On the other hand, if we have a patient where at surgery, after we cut open the uterus, we found that there is a very small growth, it is not invading myometrium, it is not involving cervix, we could omit removal of lymph node. Otherwise, by and large, for all patient, after we have taken out the specimen and after cutting it open, then we proceed with removing pelvic lymph node and parietic lymph node. And when we get our final histopathology, that will now make us decide whether this patient requires post-operative radiotherapy. Generally 4 to 6 weeks after initial surgery, we subject this patient to post-operative radiotherapy. An indication for radiotherapy are where lymph nodes are positive, where growth size was more than 2 centimeter, where more than half thickness of myometrium was there by the disease, and where we were told by pathologists that she has a poorly differentiated tumor. So these are the patients who are at an increased risk of recurrences. So for all these patients, we give them post-operative radiotherapy. So you all are aware of our cancer center, ISCH. So we run a clinic there, gynae-oncology clinic, where gynecologists sit, radiotherapy colleagues sit, and there are people from medical oncology. So we jointly sit and decide whether this patient requires post-operative radiotherapy. And once you have treated patient by surgery and post-operative radiotherapy, we need just to keep her on follow-up at least for next 5 years. Initially we call them every 3 monthly for first 2 years, and then every 6 monthly. So if patient was early stage, she has been adequately treated, this is one disease where prognosis tends to be good. There are little chance that she will have recurrence, but we still have to keep on follow up. And in case during follow up we find that no, she is developing recurrence, then we have to further treat her. So if she had an early stage disease limited to body of uterus, there are almost 75% chance that she will live life without recurrence or disease. And as stage increases, 5-year survival rates go on decreasing. For CS cervix, we know that it is a preventable cancer. In cancer cervix, we know anyone who is having sex is at a risk, and in them we tell them, Kina, please, no, you should have a pap smear testing and maybe other test, and we can disease before actual cancer develops. Is there some such thing for endometrial cancer? People have tried, let us also do screening for endometrial cancer. Initially they said, let us do pap smear, but pap smear is good for CA cervix, it is not good for CA endometrium. So pap smear is not a good method. Then people thought, let us do their once a year ultrasound to measure endometrial thickness. Then other people said, let us do their endometrial biopsies if thickness is more. But till date we don't have any effective method of finding whether patient has endometrial carcinoma. So main thing is we should provide a education to patient that if you have any post-menopausal bleeding, if you have irregular bleeding in the perimenopausal age, you must see your gynecologist. And that seems to be the method as of today. I am going to stop here. I will request Dr. Seema Singhal to speak about this part. So in case malignancy arises from myometrium, then we call it as sarcoma. Sometimes sarcoma can develop even from endometrium. You may wonder how can a sarcoma arise from endometrium? From endometrium there is only epithelial lining, it should be carcinoma, not sarcoma. But in endometrium now we have two components, epithelial component and stroma. So at times a endometrial disease arising from stroma can occur, and that is endometrial stromal sarcoma. So I'll hand over mic to Dr. Seema Singhal. I have to go to OT.
Thank you, sir. So, as sir said, sarcomas are rare tumors. They account for approximately 2 to 3% of all uterine cancers. And sarcomas are mesenchymal tumors. So, we have to understand that they will be resistant to the therapies like radiotherapy or chemotherapy. So, the predominant management will be surgical for sarcomas. That is one thing. Another important thing is the risk factors. The risk factors are a little different, and the age group is also different than the endometrial cancers. Like they will be seen more in the young patients, and most of the times they are diagnosed after a myomectomy, right? Most of the times the patient underwent a myomectomy, a young patient, and then after histopathology you find that it is a sarcoma. So that is one way of presentation. Another presentation is that yes, old age patients, usually 65, 67 years old female who is presenting to you with abnormal discharge or abnormal bleeding. These are the patients who will be having sarcoma. They may be having sarcoma, I would say. So how do we kind of differentiate? They will be having some different risk factors than endometrial cancers. The patients who had tamoxifen therapy, they are more likely to have sarcomas. The patients who underwent radiotherapy, pelvic radiotherapy, even that is another important risk factor for uterine sarcomas. Okay, so usually their prognosis is usually poor. So what is the classification for uterine sarcomas? As I said, there are two mainly. The most common one is leiomyosarcoma, the mesenchymal tumor. So leiomyosarcomas, they will be well different, low grade and high grade, that will be there. And then we have endometrial stromal sarcoma, which arise from the stromal component of the endometrium. Okay. So endometrial stromal sarcomas, once again they can be low grade endometrial stromal sarcomas, or they can be high grade or undifferentiated uterine sarcomas. And then we have so called carcinosarcoma, which was in previous classification was said as uterine sarcomas, but nowadays it is not called as uterine sarcoma. It is a part of type 2 endometrial cancer. Okay. So that is there. And then we have adenosarcoma, which has both the components, the glandular and the mesenchymal, the myometrial component. So the sarcomas with heterologous differentiation, as we said, rhabdomyosarcoma, liposarcoma and osteosarcomas. So how do they present? They present as postmenopausal bleeding, irregular vaginal bleeding, lump lower abdomen and fever. Fever can be there. But then most of the times they would present with as postmenopausal irregular bleeding and vaginal discharge most of the times. The diagnosis, how do we make the diagnosis? Diagnosis is usually the endometrial biopsy, which was so certain for endometrial cancer, is not certain for uterine sarcomas because they are myometrial tumors. So it will not give you a good yield for the diagnosis. So it is not very common. Only 10 to 15% patients you will be able to make out by the endometrial biopsy. Only endometrial stromal sarcomas may be there positive in endometrial biopsy, otherwise most of them will be negative. So how do we differentiate? The appearance, the patient's presentation, usually elderly, and then the imaging. Imaging might give you some idea that there is a mass in the myometrium which is lost its Worley pattern, and there is no interface between the surrounding normal myometrium and this, and it will be areas of hemorrhage and necrosis in this mass. So they are highly malignant tumors, so there will be areas of hemorrhage and necrosis with the loss of the distinct pattern. Okay. So these are the various features which you can make out. Imaging studies say, and then mostly diagnosis is made after surgery based upon histopathology, as I've already told you. So what is the treatment? The surgical treatment is the mainstay of therapy, and the surgical treatment is usually consisting of, because most of the sarcomas, the most important thing is they when they present, there will be extrauterine extensions there. So if they are there, then it is difficult, you know, because the prognosis is poor, they don't respond to the adjuvant therapy. So surgical management and a complete removal of the tumor. So they say it as en bloc removal of the tumor along with the uterus, the cervix, and also any part of disease which is lying outside. So depending on the differentiation of the tumor, you decide the extent of management, surgical management. For example, a patient is well differentiated like leiomyosarcoma, which is confined to the uterus, you will remove the uterus and the cervix. The ovaries in a young patient can be left alone for a leiomyosarcoma, okay, but not for the endometrial stromal sarcomas, because endometrial stromal sarcomas are hormonal dependent tumors. So you will not leave your ovaries there. Usually lymph node dissection is not required for the well differentiated uterine confined disease, but for the extended disease and for the undifferentiated disease you may have to do a lymph node dissection also for the en bulk removal of the tumor. So as I've already said that adjuvant chemotherapy and radiotherapy is having doubtful value. So prognosis of these patients, the ones with uterine sarcomas, is usually not so good as that of endometrial cancers, the endometrioid variants, and but then of course with the good surgical management, and we have to avoid, we have to avoid leaving residual disease. That is the most important determinant of your outcome of your patient. So that is the thing. So we have to remember that endometrial cancers are there in the society, and a suspicion that a patient who is presenting to you with abnormal uterine bleeding, especially in postmenopausal region, you have to investigate that so that she can be picked up early, because early detection matters for the outcome. But even for the younger patients nowadays, the patients who are coming to us as less than 40 years, who are having some infertility, PCOS or any other kind of estrogen predominant conditions, even they may be having, almost 4% of these patients might be harboring an endometrial cancer. So a thorough evaluation, a high risk of suspicion in your mind, then you have to evaluate and have to pick up the diagnosis, and that would have an outcome impact, because if you pick up early and you treat them appropriately, they will have a very good survival. That is the thing. Thank you so much for the patient.
आ सर का 2 बजे है ना लेक्चर?
हाँ,
तो सर का अपने घर से करेंगे?
तो ऑनलाइन बता रहे, तो ऑनलाइन होगा ना?
नहीं नहीं
हाई करके मैंने आपको भेज दिया है।
नहीं, ये तो जो हमारा जो